talking about position and a preference that's been around for more than 30 years. So when they asked me to do this presentation, it was a conflict of interest for me because for me it's done, it's supine, that's it. I could end my presentation here. But talking to Daniel yesterday, we need to make a presentation for this. So this is my conflict. I'm a proctor for Boston. And for the past 10 years, I'm 100% supiner. And also I got a little bit of help by the new AIs making this presentation. So when we talk about supine, we're talking about everything that doesn't mean the patient facing down. So we have oblique, we have lateral, we have different positions, and in this paper, Dr. Zheng and Dr. Zhao show us all the different positions that we can call supine. So this is the never-ending story. This has been around for 30 years, and we still are debating on it. And it was shocking for me because when I did the PubMed search, I found out that we are publishing more right now than we did 30 years ago. So I said, perfect, I have a lot of research to do. So what the AI helped me is to present you what you already know. Supine, it's better for the anesthetist. We have enhanced anesthetic management. It's better for the airway, it's better for the patient. It's safety because you are gonna have less time with the patient under anesthesia. And it's ideal for high-risk patients, especially the morbid obese, the severe cardiovascular disease where you don't want that thorax to be upside down. Also, if you have spinal deformities or, as you know, facilitates the procedures in patients that you cannot put in the prone position. As you know, when you are working in supine, the hallmark of supine is that you can do the combined surgery, you can do an SRS, and we know for all the research that we've done and that we can have improved stone clearance, even though it's not statistically significant. We have an easy retrolateral stenting, and we could potentially have a wider range of puncture that's discussable. And of course, it feels natural. I mean, we're performing everything in supine. All the proners are doing supine because you do your TURPs, your TURBs, you do it in supine. So it's the same for us. You have a potential increase for efficiency and improve ergonomics. I have people, that's Daniel Perez Fentes, one of the referents in my country. He operates sitting down. So for you, for the surgeon, it's better to do the surgery in supine. You have shorter overall operative time because you don't have to put the patient facing down and put it back in the bed, facing up again. And as I said, you have improved surgeon control. What I did find in these last 10 years of research is we have some added value to the supine. You can have access to the upper calyx, which was one of the main reasons proners were against supine because they couldn't reach the upper pole. That's not a problem anymore. And if you're doing pediatrics, this position is for you because it's better for your little patient. Also, you're gonna get less radiation, and this is proven. You can do a totally X-ray free procedure with the supine. I'm pretty sure you can do it in prone also, but it's gonna be difficult. And you can do bilateral procedures. You can be working on a PCNL in one kidney, and your colleague will be doing an RIRS in the other kidney. So this is all of the added value that we knew 30 years ago, but right now it's presented in the papers. So I know in worldwide, we're the young kid, we're the young son. There's more people doing prone in the US, there's more people doing prone in Brazil, though it's changing. And in Europe, it's more prone, especially in the east part of Europe. In Spain, we have 88% of supine PCNL done. So I think we're as the country that did the first, we're the first to convert to this technique. But what I find interesting is that every person that did prone and now it's doing supine it has never gone back to prone again. So that's something I need to tell you, and you need to know. You need to prove the supine position, and you will tell me which one you think is better, which one you think is easier, which one is better for your patient. So I could continue with all the papers that are in the literature, but that's something you can do at your home. So I'm going to tell you my story with supine PCNL. As you know, in the archaic ages, we do prone. And then by the 90s, this guy, Dr. Valdivia in Zaragoza, he just flipped this patient. And he did a series of studies where he showed us that by flipping the patient, he could get a better access to the kidney and also put the colon away, because that was one of the big concerns about the puncturing the kidney. You could hit the colon. And then on 92, my mentor, Dr. Ibarlucea, changed to the supine position and started working with that until 2004, where he had a very difficult case, and he lost his stent. So he told his colleague to put a stent through the urethra, and that's how they started. So they started to the position that we still do the same today. We first make some lines, some reference lines when the patient is laid down. We do that ultrasound to see how the kidney and the access is going to be. If we have a calyx that is posterior, we're going to fill that air bag that we still use. It's a 3-liter saline bag filled with air, and put a clamp on it. If you have a posterior calyx, you just fill it more, and if it's more anterior, you just empty it. We put it down there. We do an ultrasound again to check for our puncture point, and then we put the drape zone, and that's where you find the reference points are very helpful. It's not a problem for us because we do every puncture with ultrasound. So the main issue here is the column. You can check it again with the ultrasound, but having the reference points is very good. Also for your nurse to put the drapes on, or when you are putting the drapes on, you know what part of the patients you're leaving there. And then we just have fun. And I know it's one of the things about the combined surgeries that you need 2 surgeons to perform the surgery. But as we see it, as I see it, if you're gonna use 2 surgeons in this surgery, you're gonna be saving 1 surgery to the patient. So it's the surgeon you're gonna be using next time. So you use it this time, you save 1 operation to the patient, and you have a stone-free procedure in just one hour. I have some tips and tricks that we learned during the time we're doing. We always start the procedure in our clinics. We do the ultrasound to the patient. We're thinking we're gonna do the PCNL, and we mimic the puncture in the clinic to see if we're gonna have access and we won't have problems. Then the air bag with a clamp that you can empty if you need. We need to have the leg holders with the boot. Those are the better ones to move the patient if you need to go down with the semi-rigid or the flexible ureteroscope. We always do a 90% US puncture, and then we use the C-arm to go the other 10%, which I call the RX adjustments. And we use the guide wire through and through. That way you can be better at when you dilate, the kidney is not going to be moving. So that way, that's how we've been doing all of our supines, and I've done 99.99% of my procedures in supine since the last 11 years. And if you don't believe me, believe this guy. He's one of the best supiners we have in Europe, and he's telling supine is the way. He's been telling that for many years. And if you don't believe him, believe all of these guys. These guys are the real stars and are the masters of the supine. And they are performing it. And some of them started in prone, and now they only do supine. And this is my master. This is Gaspar Ibarlucea, the one that he was the first one to do the combined approach. And I'm his pupil. And if you have any questions, I'm that pupil, not the other one that lost the hand and killed his father. I'm the good one. And I can answer any questions you have on supine. And we have this guy that's going to try to make you go to the dark side in the next presentation. Thank you very much.
Thank you very much. Very good. Dr. Daniel is from Bucharest.
Thank you, Jorge, for your beautiful presentation. We discussed during the coffee break and that with all these advantages in technology, both approaches are feasible, and there are not so many advantages like in the past year of one method to the other. In our hospital, we perform both prone and supine PCNLs, and I recognize that some of the doctors that perform prone, a lot of prone surgeries in the past now are performing in supine position. Hopefully it is going to work. I don't have any conflict of interest. It's not working. But I would like to thank to our anesthesiologists that are supporting us in performing PCNL in prone position. Puneți-o de acolo. E singură.
If you like, we can start
We can
with
have few
questions.
questions until it's fixed.
Yeah, thank you for a very nice presentation. I used to be
Hopefully.
Actually, it's not a question, it's a brief comment. And I used to be a proner, now I'm supiner. So I went from one side, not to the, I won't say dark side or bright side. But anyway, to be objective, I mean, in Russia, we've done and published the article which called Systematic Review of Meta-Analysis on PCNL. And concerning this topic, there is a 7 meta-analysis. None of them revealed any difference in outcomes. The only difference was in supine, the fever rate, which was lower in supine position. But for me, the biggest advantages is anatomy, because all we know, if we flip a patient on the abdomen in a prone position, so the rate of the prevalence of retrocolon is going up, and almost double. So this is for in my opinion, this is the biggest advantage of a supine approach. Thank you.
So I have no conflict of interest, and as I said before, I would like to thank our anesthesiologists that are sustaining us in still doing the prone PCNL. And at the end of my presentation, if I can't convince you, maybe I will confuse you. So the first PCNL was performed back in 1976 in prone position, and as you know, in 87, Valdivia came with a new approach. But PCNL performed in supine position, which was slowly adopted by urologists during the next decades, particularly in Europe. Supine PCNL has not gained wide acceptance in a urological community, and since then there is an eternal debate about which position to choose, but still 80% I think that of urologists are still performing the procedure in prone. According to European Association of Urology, the PCNL performed in prone is equally safe as the procedure performed in supine position. And as you can see, these EAU guidelines are referring to a meta-analysis that said, citing this review and meta-analysis, apart from a decreased operating time, since we don't have to reposition the patient after ureteral catheter insertion, there was no evidence for a significant difference between prone and supine position for hospital stay, non-lower calyceal puncture rate, number of puncture attempts, tubeless intervention rate, mean postoperative blood loss, and transfusion rates. A particularly high stone-free rate with superiority in favor of prone position was found in 40 days after surgery. This finding may be attributable to factors like multiple tract in prone compared to supine. Nevertheless, the observation questioned whether limiting factors of supine position, such as collapse of the pielocalicial cavity, may overweigh the comparatively favorable gravitational fragment evacuation during supine PCNL to achieve a stone-free status. Another study used the Endourological Society PCNL Global Study database and included 5,800 consecutive patients. The stone-free rate at 30-day post-PCNL was significantly higher among prone position patients, 77% compared with 70%. The rate of failed procedure in which access to the kidney was not accomplished was slightly higher among supine position patients. Mean operative time was actually 7.4 minutes longer during supine than prone PCNL, a finding that remains true regardless of the method of tract dilation. Obtaining a safe and precise percutaneous renal access is the hallmark of a good percutaneous surgery. The prone position provides posterior access to the collecting system that theoretically enable the surgeon to puncture a posterior calyx through a broad avascular renal plane without causing significant parenchymal bleeding. A comparative analysis of CT urogram found shorter tract length and increased potential access site in favor of prone position. If you were to land on a plane, would you rather choose a narrow or a wide one? The prone position provides several advantages, including a larger surface area for the puncture site, a wider space for instrument manipulation, unlimited instrument excursion, and feasible multiple accesses. The main limitation of supine PCNL is that the flank is not fully exposed, making initial puncture challenging. Access to the posterior calyx is not always possible. Upper calyx puncture is difficult. If supine position is adopted, longer access sheet and dilators are used to overcome the longer tract faced in this position, and the mobility of the nephroscope is reduced. Another important drawback in supine is the mobility of the kidney during percutaneous puncture and subsequent dilation, especially in patients with a lower body mass index, less than 25. Kidney displacement can occur in up to 1/3 of the patient in supine. Although it does not alter the success and complication rates, it is associated with longer fluoroscopy times and therefore more difficult access. In the supine position, percutaneous puncture comes from a more lateral position on the patient flank than in prone, increasing the patient tract length. The point of which the renal access sheet enters the kidney acts as a fulcrum. The farther this fulcrum is from the skin, the less maneuverable the distal end of the sheet will be. When planning to perform supine PCNL, it may be useful to have longer length rigid nephroscope and ample sheet. PCNL in supine is increasing upper calyx endoscopic approachability to the lower calyx. We can overcome this advantage of supine since in prone position the upper calyx puncture is easier to perform and in a more medial position on the patient flank than in supine position. A review that including 60 studies evaluated the superior calyx access, performance, and safety in relation to other calyces. The results show that superior calyces access in PCNL may result in improved stone clearance rate, lower additional puncture rate, faster operation time, and no increase in postoperative complication or hospital stay. Access through the superior calyx also enables the nephroscope to be aligned with the long axis of the kidney in comparison with other access points. Torquing a rigid nephroscope in the attempt to reach different calyx is the most important cause of bleeding during PCNL and is largely responsible for increasing transfusion rate and urine extravasation. ESDs, of course, can decrease the number of puncture channels used to treat complex upper urinary stone and has the ability to improve stone clearance rate. The most popular position for ESDs is, of course, the Gadakao modified supine Valdivia position. Conversely, it has some disadvantage, including the limitation of the puncture site, especially for an upper calyx, Puncture with a risk of visceral injury, decreased perfusion pressure due to the influence of gravity during PCNL. The prone split leg position may be used for SEERS, allowing smooth insertion of the ureteral access sheath, efficient retrograde intrarenal surgery, and ample puncture space. Posterior calyx will be collected in the renal pelvis, under the effect of gravity. Both studies presented here reveal that no statistically significant differences exist between both groups regarding those performing SEERS performing modified Galdacao or Valdivia position or in the split leg position, regarding stone-free rates, operative time, number of puncture, percutaneous access time, fluoroscopic time, and blood loss. There are still some concerns that prevent SEERS from gaining more widespread adoption, because this procedure requires 2 sets of surgical equipment, 2 sets of imaging display, and 2 experienced surgery. With less equipment and surgeon, the PCNL combined with antegrade flexible endoscopy technique can also manage Stackor calculi like SEERS. Compared with flexible cystoscope, flexible ureteroscope has a larger bending angle at the front end and a wider observational range. The results show that PCNL assisted by antegrade flexible ureteroscopy had a higher stone-free rate and required fewer percutaneous tract with a shorter operation time compared with standard PCNL. Performing antegrade flexible ureteroscopy can maintain low pressure perfusion of the kidney, which helps to decrease the risk of postoperative infection. PCNL performed with flexible nephroscope has also been reported to significantly improve the stone-free rate and Stackor stone and to make the procedure safer. It was stated that the prone position is associated with a higher risk of urinary tract infection because of the high pressure in the pelvis. In the supine position, the angle of the renal sheath typically is parallel to the floor, and this is opposite to the orientation of the renal sheath during a prone PCNL, where the sheath is angled towards the ceiling. High level of intrapelvic pressure may be reached intraoperatively irrespective of the technique when inflow and outflow are not balanced and may cause pilovenous backflow as well as rupture of the collecting system. Intrarenal pressure lower than 30 centimeters of water should be maintained during our endoscopic procedure. Duration of increased intrarenal pressure, the amount of perfusion pressure, obstruction, and irrigation fluid volume are independent predictors of complication development. In the supine PCNL, the only way in which we can reduce the intrarenal pressure. The addition of suction to PCNL is changing the way modern day PCNL is performed. Study demonstrated that suction might help decrease procedural time and intrarenal pressure, is reducing the risk of sepsis, is improving stone clearance, enhanced vision, and improved lithotripsy efficiency, which make it a very attractive evolution for PCNL in any stone volume. We can connect nowadays a mini nephroscope to a pressure suction in order to reduce intrapelvic pressure. A study published in 2016 showed that the infection rate was only 6.4% among urolithiasis patients with a UTI, similar with those patients without UTI who were treated by this modified mini PCNL, but significantly lower than those patients with UTI who were treated by traditional PCNL. To overcome higher intrarenal pressure, mini PCNL system provided with aspiration sheet have been introduced. The real-time suction of irrigation fluid, stone fragments, and blood throughout the procedure are lowering intrarenal pressure, ameliorate visibility, and quicken the procedure. Vacuum PCNL via 16 French clear Petra sheet is characterized by a good safety profile and satisfactory stone clearance rate. The most interesting feature in this technique are the easy suction mediated stone fragments removal, the low complication rate, and the favorable intrarenal pressure profile. Vacuum assisted mini PCNL overcome the advantages of supine position in which the capillarity effect is more efficient due to gravity and the intrarenal pressure is reduced to the horizontal placement of the ampla sheet. You don't need supine position in order to evacuate fragment after PCNL. In this case, we are using 14 French clear Petra ampla sheet, and we don't need to dust the stone, but we can do it at the beginning of procedure, and then it's easy to fragment it and to extract the fragments on the ampla sheet during the extraction of the scope. The advantages of simultaneous bilateral stone removal are evident, and this procedure can be performed much more easier in prone position. At the end, I would like to remember this global study that showed that stone-free rate was better in prone position with similar safety profile. I hope I convince you, and I'm letting you to discover the artist in every one of you, and to carve the kidney stone the same as our famous Romanian sculptor Brâncuș carved the marble. Thank you.
Thank you very much.